The main organ is the uterus, and the function of the uterus is to house and nourish a developing fetus. And when there is no fertilization occur, then the menstrual cycle will happen. And in this case, we're talking about uterine prolapse. So this condition affects women who have had multiple vaginal deliveries, or women who deliver large babies, also affects women who is postmenopausal.
Uterine prolapse is a form of pelvic organ prolapse (POP) where the uterus descends from its normal position in the pelvis into the vaginal canal. This occurs when the muscles, ligaments, and supportive tissues of the pelvic floor become stretched and weakened, failing to provide adequate support for the uterus. Here is the diagram, which is a breakdown of the stages in uterine prolapse. In normal anatomy, it shows the typical position of the uterus, bladder, rectum, and vagina. The uterus is held in place by pelvic floor muscles and ligaments. In stage 1, the uterus has descended, but is still only in the upper half of the vagina. This is the mildest form and may not cause significant symptoms. In stage 2, the descent is more noticeable as the uterus has descended nearly to the opening of the vagina or the introitus. The symptoms often became more apparent at this stage. And then we have stage 3, where the uterus has prolapsed further and now protrudes out of the vagina opening. This is a significant prolapse and usually causes noticeable physical discomforts and other symptoms. And then the last stage is stage 4, which is the most severe stage, where the uterus is completely out of the vagina and is known as presidentia.
Okay, so for now, I will be talking about the etiology and the pathophysiology process. So for the etiology, I will start with the childbirth trauma. Women who have experiencing large baby delivery, prolonged labor, and even surgical instrument usage will have their pelvic floor muscle to decrease in strength because of the direct impact towards it. Next, we have chronic pressure on pelvic floor. So, women who have condition like obesity, chronic cough, or even constipation will likely to have this condition because all of these three will order the pelvic floor muscle to constrict out of their capability and will decrease their strength. Next, we have heavy lifting. Bear in mind that there is nothing wrong with exercise, but remind yourself that you need to prevent to use additional weight that above your capability. Just use your healthy weight. Next, aging and menopause also lead to this cause because, as we all know, estrogen are one of the hormones that help with the strengthening of the pelvic floor muscle. So when we're aging, our estrogen level will drop. So when the estrogen level drop, the strength of the muscle will also significantly drop. After that, we have past pelvic surgery. For example, hysterectomy. Hysterectomy is the process that we remove the uterus. So when we remove the uterus, the pelvic floor muscle will lose their main purpose because the purpose of the pelvic floor muscle is to support our uterus. So when the uterus is gone, same goes to the function of the muscle, so it will decrease the strength. Last but not least, we have genetic predisposition. So this is quite rare, but there is a chance that this will be inherited and the collagen and even the ligament will have a weaker that the baby will get. So So next, let's talk about the pathophysiology. So the main purpose of the pelvic floor muscle is to support the uterus, but when the muscle is exposed to conditions that strain the muscle like chronic cough, obesity, heavy lifting, prolonged labors, the muscle itself will lose their elasticity, and it will lead to uterus to descend downward towards the vaginal canal. So I would like to remind that uterus might protrude outside vaginal opening that might cause discomfort. Usually, it will happen at the stage 3 or stage 4.
Clinical manifestation, the patient might feel heaviness or pressure in the pelvis. A bulge or tissue might be seen or felt coming out of the vagina. Low back pain, vagina dryness, irritation or bleeding. And in sexual dysfunction, they might feel pain during intercourse, which will decrease their libido. In urinary symptoms, leakage, frequent urination, or difficulty in emptying the bladder. Next is bowel symptoms, constipation, or the need to press the vagina in order to pass stool.
For health assessment, we're going to start with the objective data. And for general assessment, we're going to observe for the posture, gait, and signs of discomfort, especially on the pelvic organ area. And then we're going to check for associated pelvic pressure symptoms. And then next, we're going to for pelvic examination. This is to assess the degree of uterine descent, and then to inspect for visible bulge or protrusion from the vaginal introitus. And next, we're going to observe for descent of the cervix or uterus into the vagina. And lastly, this examination is to assess the size, shape, and position of the uterus. For the subjective data, patient will complain a sensation of a feeling something coming down from the vagina, and also there is history of feeling of vaginal fullness or heaviness, and this will be more noticeable when standing. It got worse and improved when lying down. Also, symptoms like urinary incontinence or retention, also low back pain or pelvic discomfort, and it also have symptoms of dyspareunia, which is pain during intercourse. And then for the obstetric and gynecologic history, a patient have history of number of pregnancy and vaginal deliveries, and also patient have history of prolonged labor and instrumental deliveries, such as the usage of vacuum for delivery, or history of trauma during delivery, and also menopausal status, and other relevant histories such as chronic cough, constipation, heavy lifting, and also a family history of pelvic organ prolapse.
First is pelvic examination, where it is the main method used. The doctor will check the vagina while the patient lie down and standing. You may be asked to cough, bear down in all four, or strain in order to see how far the uterus descends. It can help to confirm the presence and degree of prolapse. Next is pelvic floor muscle strength. This is to assess how strong and coordinated the pelvic muscles are. The examiner will insert 2 gloved fingers into the vagina and ask the patient to squeeze as if they are stopping their urine from flowing. The strength, duration, and control of the contraction will be noted and graded using the Oxford grading scales from 0 to 5. 0 is no discernible pelvic floor muscle contraction, and 5 is a strong pelvic floor muscle contraction. Hopkins system. This can help to measure specific vagina point to classify the prolapse from stage 1 to stage 4. The examiner will measure 6 specific vagina points. Each point is to measure relative to the hymen, which means the hymen is the reference point. 0 is at the hymen, negative is above the hymen, and positive at below the hymen. And there might be an additional measurement including genital hiatus, perineal body, and total vaginal length. Imaging test. First is ultrasound. It is used to visualize the uterus, ovaries, and surrounding organs, and to rule out other causes like fibroids or masses. Next is MRI. It will provide a detailed image and is more helpful in complex or recurrent prolapse cases. Difficography is more like a position or a technique that is used if bowel symptoms are present to assess rectal and vaginal wall movement during defecation.
So let's move on to the medical and surgical management. So for the women who have this condition, they can consider to use the pessary insertion for the medical management, which is a device that are removable and adjustable, inserted into the vagina to provide support to the uterus. So when there is a support to the uterus, the pelvic floor muscle will less likely to be strained. So to use this device, nurses should consider the patient POV because this device can be used temporarily or permanently.
Moving on to surgical intervention, where we have vaginal hysterectomy, which is a surgical removal of the uterus womb and cervix through an incision made at the top of the vagina. The purpose is to eliminate the major prolapsing organ, the uterus itself, and prevent recurrence of the uterine prolapse. This vaginal approach is often preferred when uterine prolapse is the primary issue because it offers fewer complications and a faster recovery compared to abdominal surgery. And then we have prolapse repair, which is a procedure to repair and strengthen the weakened pelvic floor tissues that were allowing the organs to prolapse. The term colporrhaphy specifically refers to suturing and repairing a defect in the vaginal wall, which is to restore the support to the adjacent pelvic organs, which often prolapse along with the uterus. Next, we have uterine suspension or hysteropexy, which is a surgical approach focused on preserving the uterus while correcting the prolapse. This is a key option for women who still desire future childbearing, since the uterus is preserved and the potential for future pregnancy remains, and for those who wish to avoid hysterectomy, because some women prefer to keep the uterus for personal, cultural, or medical reasons. Next, we have sacrohysteropexy and sacrocolpopexy, where both procedures use the same fundamental principle, which is suspending the prolapse organ to the strong bone of the sacrum, but they are applied depending on whether the uterus is still present or has been removed. Sacrohysteropexy focuses on treating uterine prolapse while keeping the uterus intact, where a synthetic mesh is attached to the back of the cervix or the lower uterus and is then securely fixed to the bony ridge of the sacrum or sacral promontory. This procedure is either for women with uterine prolapse who still desire future fertility or wish to avoid a hysterectomy as discussed previously. Sacrocolpopexy focuses on treating vaginal wall prolapse, where the top of the vagina collapsing after a previous hysterectomy. Sacrocolpopexy uses a synthetic mesh, which is then attached to the top of the vagina or the vaginal vault and is then securely fixed to the sacrum. Sacrocolpopexy is ideal for women who already had a hysterectomy and are now experiencing the vagina collapsing in on itself, or for women undergoing a hysterectomy concurrently with the prolapse repair. Both surgical approaches are primarily laparoscopic or robotic, as this minimizes the incision size, leading to less pain, less blood loss, and a faster recovery compared to traditional open abdominal surgery. The dimension that we have is colpoclasis, which is categorized as an obliterative procedure, meaning it eliminates the structure of the vaginal space itself. This is very different approach from the reconstructive procedures like hysterectomy, colporrhaphy, and sacrocolpopexy, as they aim to rebuild and maintain the original anatomy, but colpoclasis does not. The key features of colpocalysis is that the walls of the vagina, both interior and posterior, are surgically sewn together that effectively shorten and close the vaginal canal. This provides immediate, securing support to the bladder, rectum, and the top of the vagina that prevents them from prolapsing. Colpocalysis is ideal for elderly or frail patients because the surgery is shorter, involves less blood loss, and has a significantly reduced recovery period, making it safer for those with serious medical comorbidities. And then it is ideal for the patients with severe prolapse, especially for stage 3 and stage 4 prolapse, and for the patients who are no longer sexually active, because this is a crucial consideration as the procedure permanently prevents vaginal intercourse.
For the pharmacological interventions, the main intervention is by administer estrogen therapy. This is to strengthen and maintain the tone of the vaginal and pelvic tissues. This is aligned with the estrogen main function. And for example, estradiol vaginal tablet and conjugated estrogen cream. And next is lubricants and moisturizer. This is to relieve vaginal dryness and discomfort. For example, like Replens and KY jelly. And next is stool softeners or laxatives. This is to prevent constipation and straining. Doctor will prescribe this for certain patients. For example, like lactulose and glucosate sodium. And lastly, analgesics. This is to relieve pelvic pain or discomfort. For example, like ibuprofen and paracetamol.
Non-pharmacological intervention. First is pelvic floor muscle training. In exercise term, it is called bridge. The patient needs to do a 3 sets of 10 to 15 contractions daily, each held for 5 to 10 seconds in order to improve muscle tone, support, and bladder control. Second, pelvic floor physiotherapy or biofeedback. This will be guided by physiotherapy and may include electrical stimulation or feedback devices to improve muscle control. Last but not least, lifestyle and behavioral modification. The patient needs to avoid heavy lifting or prolonged standing, as this will increase abdominal pressure, and they also need to prevent constipation by eating high fiber foods and drink enough water.
Uterine prolapse can cause urinary problems like incontinence, where urine leakage when you cough or strain, like stress incontinence, and then urine retention because of difficulty starting or finishing urination that leaves the old urine behind, like what we call voiding dysfunction. And then it can also cause bowel problems like constipation because of difficulty emptying the bowels that often require manual rectum evacuation. Uterine prolapse also can cause local damage and infection because of ulceration. This happens when the protruding tissue rubs against clothes and dries out, causing open sores, irritation, and bleeding. And then it causes infection because of poor bladder emptying, or what we call voiding dysfunction, that leaves behind urine that increases the risk of recurrent urinary tract infection (UTIs). In long-term run, uterine prolapse can cause kidney damage or hydronephrosis. In the most severe cases, like in stage 4, the prolapse can physically pinch the ureters that drains the kidneys, causing urine to back up and potentially leading to permanent kidney failure. Uterine prolapse can also affect the affected women's quality of life because of pain and pressure. This is because a constant and heavy feeling, often described as sitting on a ball, and then it can affect the sexual dysfunction because of pain or discomfort during intercourse, or what we call dyspareunia.
The first nursing diagnosis is acute pain related to pelvic muscle strain and pressure from prolapse uterus as evidenced by patient verbalize lower abdominal or back pain and discomfort when standing or walking. So the goals will be patient will verbalize pain reduction to an acceptable level between 0 to 2 within 24 hours. And the patient will demonstrate non-pharmacological pain relief measures such as rest and positioning. So for the intervention, first assess the location, intensity and duration of pain using a pain score scale every 2 to 4 hours. This is to establish baseline data and evaluate pain relief effectiveness. Second one, to encourage bed rest in supine position with elevated legs or hips to help relieve pressure on the pelvic floor and decrease pain. The third one, to administer analgesic as prescribed by the doctor such as paracetamol to provide pain relief and promote comfort. Next, to teach relaxation and breathing techniques such as deep breathing technique to reduce anxiety and help the patient to cope with pain. And lastly, to advise patient to avoid prolonged standing or heavy lifting. This is to prevent increased intra-abdominal pressure that can worsen the discomfort. For the evaluation, patient verbalized pain reduction to an acceptable level between 0 to 2 within 24 hours, and patient demonstrated non-pharmacological pain relief measures such as rest and positioning. The second nursing diagnosis is urinary retention related to pressure on the urethra and bladder neck secondary to uterine prolapse, as evidenced by frequent voiding in small amounts, bladder distension, or post-void residual urine. So the goals, patient will be able to void freely without discomfort or retention after interventions. Assess urinary patterns such as frequency, amount, urgency, and residual volume. This is to establish baseline data and helps evaluate bladder function. And encourage regular voiding schedule for every 2 to 3 hours to prevent overdistension of the bladder and promotes bladder retraining. And assist the patient into an upright or normal voiding position to promote relaxation of the pelvic muscles and improve bladder emptying. Next, to apply warm compress or provide privacy during voiding times to help relax the perineal muscle and stimulate micturition reflex. And lastly, to monitor for any signs of infection such as burning, cloudy urine, and fever, because retention increases infection rates and early detection prevents complications. For the evaluation, patient was able to void freely without discomfort or retention after interventions. For the third nursing diagnosis, body image disturbance related to altered appearance and function of the reproductive organs, as evidenced by verbal expression of embarrassment, low self-esteem, or avoidance of sexual activity. Patient will verbalize acceptance of her condition and express feelings openly throughout hospitalization, and patient will participate in decision-making regarding treatments such as pessary use and surgery. First, encourage verbalization of feelings about the prolapse and its effects on self-image. This is to provide emotional support and help the nurse to assess coping mechanisms. Next, provide privacy during care and discussion to promote comfort and trust, and then offer information about the condition, treatment options, or prognosis. This is to reduce the fear of the unknown and increase patient control. Next, refer to counseling or support groups if needed to provide ongoing emotional and psychological support. And lastly, include the family members in discussion about care and recovery to encourage support and reduce isolation or guilt. So for the evaluation, patient verbalized acceptance of her conditions and expressed feelings openly throughout hospitalization, and patient participated in decision-making regarding treatments such as pessary use and surgery.
In summary, uterine prolapse can be developed through our lifestyle, genetically, or even obtained after multiple deliveries. Even though the mild cases can be resolved naturally, surgical and medical intervention can be taken to ensure comfort for daily living. Understanding uterine prolapse by knowing the clinical manifestation is essential as early detection of the condition.